Thank you very much, Muaf. Assalamu alaikum, everybody. First of all, let me apologise for not being there with you in person. I was in Saudi very recently, and I've actually just come back earlier this week from a trip to the US, and I'm travelling again tomorrow. So, I mean, unfortunately, I can't be there in person, but I'm very grateful to Professor Al-Barak and Muaf and the team for the invitation. What I hope to do in the next 20 minutes or so is share with you some of our experiences of using digitized electronic health record-derived data for population health research, and just give you a bit of context. I lead the Centre for Medical Informatics, which is part of a new institute, an Institute of Population Health Sciences and Informatics that we've established at the University of Edinburgh. I just want to begin by sharing with you my disclosures. And so, as you can see, I've had research grants from a number of bodies. I don't think these materially impact on what I have to say, but I'm just doing this in the interest of transparency. So what I want to do, by way of overview, is to think about how we can begin to use the emerging digitized infrastructures, and they are emerging really everywhere in the world, including Saudi Arabia, and do this in three particular contexts. So think about descriptive studies, look at quasi-experimental studies when we're trying to evaluate health policy interventions, and think about how we can begin to scale up and increase the efficiency of the clinical trials that we run. I then want to move from these kind of standalone individual studies to think about how we might generate a learning health system, which allows us to use data on an ongoing basis. As I mentioned, I've recently come back from a WHO mission to the Kingdom, and what I want to do is share some personal reflections on how we can actually promote population health capabilities in Saudi Arabia, and hopefully I will leave time for questions at the end. So I want to just begin by providing a bit of context and about where I'm coming from. And this is it's a very famous slide from the Commonwealth Fund in New York, which evaluates health systems from across OECD countries. And it does it on a variety of parameters, particularly relating to quality. And as you can see, the UK figures particularly highly in this respect. It comes out, overall very well. And on the bottom row there, you have the cost per capita of healthcare. And so it's a very efficient health system. I think part of the reason for that is that we have, just incidentally, next to the UK, you can see the US on the extreme right, which comes out actually poorest, and that's been a consistent finding over many years. I think part of the reason for this is that we do have a genuine national infrastructure and national health system, which provides care free at the point of care from cradle to grave. And this is an image from the Olympic ceremony, that's the opening ceremony that we had a few years ago. And I think in the Kingdom you have a very similar model, but there are, of course, variations, but potentially you can achieve something quite similar. Another key factor here is that we have had electronic health record infrastructure, particularly in primary care, for about 20 years or so now. So this is a mature infrastructure. These electronic health records began by clinicians devising their own record system. So this was a bottom-up development rather than a sort of top-down commercial development. There's been consolidation into three main vendors. They are listed there. I think the names are perhaps not of that great interest, but really the key point here is it was a bottom-up development that allowed then consolidation across the UK. These record systems now include a full suite of functionalities, so CPOE, CDS, which I'm sure you've been hearing about in the conference. We have lab functionality and increasingly electronic transfer of prescription capability as well. These record systems contain both structured, coded data, but also free text data. And increasingly, these are being used for a variety of purposes, not least used in a pay-for-performance kind of measure, whether this is linked with quality indicators and our national guideline targets. So this becomes really the bread and butter, and really in general practice, it becomes impossible to survive without this electronic health record capability. The situation in our hospitals is less well developed. So it's really the opposite that you have in Saudi. where our hospitals are still predominantly paper-based, although now around a third have moved to electronic health records, and the aim is that transition will complete within the next 5 years or so. What we also have is the ability to link our records. This is both in Scotland and in England, our electronic health records with a variety of other data sets. And the reason we can do that is because we have a unique identifier. So just to illustrate that, in Scotland, for example, we can link via this unique identifier from cradle to grave, and this is a range of healthcare data sets, and I'll explain later on, increasingly a range of non-healthcare data sets. So that's the context I wanted to sort of provide a bit of background information. And then I wanted to just share with you some examples of how we've begun to use this data infrastructure for population health research. So these are just a few examples. There's lots more potentially that I could have shared. So I'm going to begin with the most basic epidemiological studies. As I noted on my opening slide, I also practiced as an allergist. And so one of the areas that, and this is the first piece of work I ever did really, using routine data, this was looking at anaphylaxis. Anaphylaxis is a rare clinical allergic emergency, affects well short of 1% of the population. So if you want to study this disease, you could only do it at scale using routine data. Doing it using sort of de novo research or primary research is very, very challenging. Nobody can really do that. So there were concerns in the UK that there were potentially increases in anaphylaxis taking place. So we looked at admissions over a reasonable time period, over a short time period, across the whole of England. So this was using population records, and as you can see, there was an increase taking place. So we reported this in the BMJ, and then there were some concerns expressed. Well, it's a very narrow time period, and there is also diagnostic shift potentially taking place. So then we extended this from the ICD-9 to also include the ICD-10 period, and looked at a range of allergic disorders, systemic allergic disorders, just to try and evaluate whether there may be diagnostic shift taking place. And as you can see, the trends are all in the same direction, so this was fairly conclusive. But without a genuine population-based infrastructure, this kind of work or that clarification would have been completely impossible. So this is the kind of basic sort of work that can be done. This is some work that we did for our House of Lords allergy inquiry, and this was trying to look at clinician workload in the context of eczema. Now, those of you who work clinically will know eczema is predominantly a disease of childhood. It tends to relapse in the majority of children. Adults tend to be disease-free. But however, what we were able to see here was that consultation rates remained high in those with a diagnosis of eczema over the life course. We were then able to attribute cost to this and provide a cost estimate of how much it costs to care for a person with eczema over the life course and take this into health policy deliberations. This was a piece of work that our Chief Medical Officer asked us to do. We were rolling out a national disease strategy for improving outcomes for chronic obstructive pulmonary disease. And as part of the baselining, we were asked by Sir Liam Donaldson to look at where the hotspots in England are. So this is being used for public health sort of measures. And the reason why this is important is that most public health interventions actually exacerbate inequalities unless you have targeting taking place. So another sort of example of how we began to use this data. I want to move from simple descriptive studies to more analytical studies. And so there were some concerns around asthma may adversely impact on exam performance. So we took that GP data and linked it with hospitalization data, but then also we did an example of cross-sectoral data linkage. So we linked these data with exam data, and we were able to show that there was no adverse impact of asthma on exam performance. So that was a very large case control study. And this is a very busy slide, but all I wanted you to do is look at these numbers here, which are very, very large. So this was an attempt to produce our own cardiovascular disease risk algorithm, which we did a derivation cohort and a validation cohort using routine data only. So this is something like over 30 million patient years of data, and this is my cardiovascular risk profile. So what we have the ability to do is generate these cardiovascular risk algorithms using our own data, and to update these on a daily basis and then feed these into sort of routine clinical decision making. We've done the same for diabetes, which is particularly pertinent to you in Saudi, but we've also done this recently for COPD, for example, as well. And if you want to sort of enter your own profiles, you can do it through that link there and assess your own cardiovascular risk over the next decade. Another example of pharmacovigilance. So recently, varenicline is the most effective treatment for preventing or helping people stop smoking. However, the FDA in the US recently raised concerns that there may be neuropsychiatric and cardiovascular side effects associated with this. These were on the basis of relatively small-scale studies. Here we did a retrospective cohort study looking at over 160,000 patients, and we're able to establish actually there is no increased risk on either of these outcomes. And this work has been fed back into the FDA, and it will hopefully trigger an FDA review. In Scotland, we're very interested in inequalities. It's really centre stage in our national policy making. So for the first time in the world, what we've done is we've taken hospital data, linked that with mortality data, and linked that with census data, which has data on ethnicity or race and a variety of confounding measures. So we have these data on 4.6 million people, and what we've done is we've created a heat map of ethnic disparities in a variety of diseases, so cardiovascular disease, cancer outcomes, early life outcomes, mental health outcomes, etc. So this is one example I want to share with you of what we've done in relation to asthma variation. So you can see that there are vast variations by ethnic group in the risk of hospital admission, but no real differences in risk of readmission. And this is done on 4.6 million people out of 5.2 million people. So this is, there's no risk of bias in these data at all. So as I hope you begin to see, what you can do is do basic epidemiological work, but increasingly very sophisticated epidemiological work, which involves linkage of a variety of data sets. If you have a unique identifier, and if you have that unique identifier, you can actually seed a lot of non-healthcare data sets and do some very interesting and important cross-sectoral work. I want to move on to quasi-experimental studies, and this is, I think, very important because what this is important is in relation to where ministries of health or governments institute new policies. Now, typically these go unevaluated, but I think if you begin to have a population health research infrastructure, you begin to have the tools to evaluate. So just to give you a couple of examples. So those of you who have been to London recently will know that we introduced a low emission zone. So heavily polluting vehicles are taxed if they come into London. And the reason for doing this was to try and improve respiratory outcomes in children. So what we did is we took healthcare data, so GP data and hospitalization data, and we linked this with pollution data and meteorological data in London to evaluate the impact of the low emission zone. And what we found so far is that there is no impact on respiratory health. So, a great policy, a great idea, but at the moment it is producing no benefit of the kind that was envisaged. So before other cities in the UK or other cities elsewhere in the world roll this out, it's important that they take stock. And before we had this infrastructure, we would never have been able to do this. Another initiative that's come really from the UK is the impact of smoke-free legislation. It's now a key kind of consideration in the framework for tobacco control. And so we recently did this very large meta-analysis looking at the impact on paediatric outcomes. One of the gaps that we identified that we knew relatively little about perinatal health outcomes. So what we did is we looked at, we took 10 million births from across the UK, or close on 10 million births, and looked at the impact of the introduction of smoke-free legislation at various time points. And what we did is we did some very sophisticated modelling. So we looked at counterfactual scenarios and constructed an interrupted time series of the impact of the smoke-free legislation, and were able to demonstrate that there was a 10% reduction in perinatal mortality as a result of this. So a very dramatic effect, studied at scale by looking at 10 million births over a really a long time period. So this is there's another example, but this is an example of a health policy intervention which has clearly worked. I want to give an example of a communicable disorder, because you guys are having these problems all the time, whether it's with sort of MERS or coronavirus or H1N1, for example. So we recently also had a pandemic, influenza, and what we did is that policy was rolled out, so interventions were rolled out in real time. We linked our data with virological data sets and also with mortality data sets to allow an evaluation of the effectiveness of these interventions in real time. And what we were able to show nationally, sort of Scotland-wide for the first time in the world, was that these interventions were proving very effective. The trouble is that by the time we got through permissions and regulatory approvals and IRB, etc., we got an answer 3 years too late. So now what we're doing is we have prepared for the next pandemic. Now, inshallah, we won't have one, but if we have one, we have our data sets linked, we have our permissions in place, all our regulatory approvals. So what we can be able to do is provide our government and our policymakers with real-time answers. So I hope what I've begun to do is just give you a few examples of how policy, where health really is won or lost, can be evaluated in next to real time using these population health data sets. So in this last bit, I want to move on to clinical trials, because clinical trials, I mean, I know you don't do very many of these in Saudi, but I hope you will in the future. These are very expensive, sophisticated endeavors, but our electronic health records can really help in this respect. So this is an example of a trial that we did recently looking at telehealthcare interventions for asthma. Now, the point I want to illustrate is how many patients we needed to screen. So over 300,000 patients to randomize just shy of 300 patients. Now, you can only do this efficiently if you have electronic health records and you put together some decision rules. And so most of this screening is done digitally. It's not done manually. So that's one example of how you can increase efficiency into clinical trials. Another one is if you can look at, if you can use routine data for the outcome. So this was a trial that we did trying to reduce prescribing errors in general practice, and our intervention was a pharmacist using an informatics capability. So this involved randomizing over 500,000 patients, a big cluster randomized controlled trial, but all of our outcome measures were assessed using digitized data. So these were, for example, beta blockers being prescribed to those with asthma. And you can only do these big cluster randomized controlled trials if you are using routine data. What I also want to illustrate here is that what we did is we used a comprehensive cohort design. So what we wanted to do was evaluate secular trends. So we took millions of patients who were evaluated at the same points, who were not participating in the trial, and look at the trends in relation to these key outcome measures. So for example, those being prescribed non-steroidal anti-inflammatory drugs with a history of peptic ulcer disease without appropriate gastroprotection. So I mean, these are very, very sophisticated designs, but are only really feasible using this infrastructure. One of the difficulties that we have at the moment is that we find it very difficult to recruit into trials, and this is because our clinician gatekeepers are very busy. So what we are now trying to do is bypass this by allowing patients to say if they want to participate in studies and allow their records to be interrogated at source against various inclusion-exclusion criteria. One initiative that we've got at the moment is SHARE, which is a big Scotland-wide database. We have over 100,000 patients who have signed up to this. You can go onto the website, have a look at this. There's a very great short video on this. Our target is 1 million patients in Scotland. That's 1 in 5 of the population will say that they want to be randomized into various trials, and we're well on our way to trying to achieve that. So I think what I wanted to say in this section was that you can begin to think laterally and think about how this infrastructure can begin to support the recruitment piece, the selection, the assessment of outcomes, and also the interpretation of trials, which are typically done in very sort of small subsections of the population, but how do trial findings compare with the general findings? Okay, I want to move on to talk about, because these were all individual studies, individual teams, permissions, etc. How can we try and do things at scale and really create learning health systems? Now, a learning health system is a model that comes from the Institute of Medicine, and I'm very happy to share all of these slides, so nobody needs to take notes really. But what it is about is to allow us to use these routine data all of the time, in real time, to support decision making, both in terms of clinician decision making, but also policy decision making. And wherever that is not possible, where there are data gaps, we should then institute a research cycle. So it's this virtuous cycle that you have in the bottom right, and that book there, which is freely downloadable from the Institute of Medicine, is really the benchmark for this idea. And what we're trying to do in the UK is to try and institute a learning health system. Part of the way we've done that is we've brought together a very large national informatics capability, the FAR Institute, which you should try and have a look at. And really, what we're trying to do, what we're trying to do with that is really identify our data sources, create the means to securely link those data sources, and create the capabilities to interrogate those data sources in real time at scale. And there's very large, so there's about to be £100 million investment in this initiative because the UK sees this as really strategically important. Right, so I want to just give you a few reflections on what I think this means for Saudi and how you can sort of really begin to maximize your opportunities in the respect. And what I want to kind of emphasize is that these are my personal reflections. They're not part of the kind of WHO recommendations, which will be coming out later. I think the first thing is that, I mean, what is center stage clearly for your Ministry of Health and your government is the Saudi National Transformational Project. And what you need to do really, policy-wise, is really strategically align your thinking and any pronouncements and suggestions you make with that. I think there are opportunities because this is an opportunity. These data that you have or you can develop are potentially your next liquid gold asset. This is an area where there's going to be enormous job opportunities in terms of data processors, data linkage people, data analysts, cryptography, etc. These are enormous growth areas. If you look at any sort of projections from anywhere in the world, these are the areas that are going to grow and grow very, very rapidly. So I think you have clear opportunities for linking. Now you have, a plan that is in place, but at the moment still much of your frontline staff do not have capabilities to use electronic health records infrastructure, even basic infrastructure. So I visited centres in Dammam, Tabuk, Jeddah, Riyadh, Makkah. I mean, I've been to lots of cities, seen lots of centres, and there's a Ministry of Health plan in place. So I think you should put pressure on your government, on your Ministry of Health, just to begin implementing that plan. It's quite reasonable. Don't wait for perfect. Don't wait for the Lamborghini plan, just begin with implementing a basic plan and then build from that. And the third is that, I think if you're going to really exploit data, everybody needs a unique identifier. Now, countries which have done this can really capitalize. Other countries where they can't do this, like the US, for political reasons, are really struggling. So this is something that you should think about doing up front. It's strategically incredibly important. Now, more difficult is point 4, is around that interoperability. It's incredibly challenging. People are struggling all over the world. My suggestion is that you focus on a few core issues and you think about building a core spine which allows secure data transfer. An information governance strategy you can build. There are models elsewhere in the world. There's an important document that I'm working on for ministries of health in OECD countries, for example, and in due course we'll be very happy to share that. And I think the last point is I think you do not do this anywhere near enough in Saudi Arabia, and this is both in terms of the nationals and the expats. You have to invest in your human capability because, if you do not do that, you will lose people, and people are in short supply, very skilled people. These people who can really process data, analyze data, are in demand all over the world, and unless you do this, you will definitely lose that capability. One program that I've been involved in that you can have a think about, and we have some Saudis on this, I've been with them earlier this week in Boston, is we've created a national program on safety, quality, informatics leadership led through Harvard. We have scholarships available for people from MENA countries, so you should have a look at that. Just type in Harvard and Squill and you'll find this and details of the scholarship. But it's all about developing capability to really capitalize on this. So the last thing I wanted to say is that these data increasingly, particularly as we link them and mature them and develop the capabilities to mine these data, are really sort of incredible gold mines. We are just at the beginning of that journey. I think in the UK, we're probably sort of ahead of the world. Scandinavia is also doing incredibly well. But I think in Saudi Arabia, just as with so many other things, you have the opportunity to leapfrog. But I think the real thing is to really be thinking laterally and thinking creatively in this respect. So I'm very happy to sort of open this up for any questions, clarification, and discussion. And I mean, anybody can feel free to contact me at any point in time if I can be of any help. And of course, you're very welcome to come and visit me in Edinburgh at any time. Thanks very much.